Good morning, everyone. Welcome to another Changing the Way We Work community of practice for Ontario family physicians. My name is Ali Damji, and I will be your moderator for today's session. We're really looking forward to the session today, which is going to cover infectious disease updates and, very exciting, best practices for MSK imaging. Next slide, please. I'm going to turn things over also to Dr. Varughese from the OCFP to welcome you all to the session.
Thank you very much. And as we go to the next slide, I'll do the land acknowledgement. We acknowledge that these lands on which we are hosting this meeting include traditional territories of many nations. The OCFP and the DFCM recognizes that the many injustices experienced by the Indigenous people of what we now call Canada, continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve their health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Thank you and welcome to our session. I'll turn it back to Dr. Damji.
Great, thank you so much. And just to give a brief reflection as well too before we start today, I really encourage everyone to again think about potential access and how are we actually ensuring that people are able to access the care that we're recommending to them? Because when we think about some of the Indigenous communities and in particular the ones in rural Ontario and remote parts of the province, there are many situations where people don't have access to some of the things that we may be talking about, whether that's testing, imaging, and other types of interventions. And so I want you to have a keen eye today as you're thinking about this and thinking about not just how this applies in our own setting, but perhaps how this could apply in other settings as well and what advocacy might be needed to ensure that people can receive equitable care. So I'll leave you with that and we'll move on to the next slide. So as a reminder, this is an accredited program, and I want to just also take this opportunity to briefly thank our planning committee as well too for all of their contributions in helping us put together this session, as well as thanking our speakers for giving us their time today. Next slide. If you did miss a session and you want to earn credits, there is the self-learning program that's available. You'll see a message about this popping up in the chat as well. And this program allows you to earn credits for watching the past sessions. You just have to click the link and fill out a 60-second form after you watch the session. Next slide. This will be our order of speakers today. Really looking forward to hearing from them both. And we'll just move on to the next slide to allow them to introduce themselves, starting with Dr. McGeer.
Morning, everyone. Nice to be back. As you know, I do a lot of work with companies that make vaccines and therapy for viral illnesses, and you can see my relationships on the slide. Over to you, Dan.
Hi, morning, everybody. Daniel Warshafsky. I have nothing to declare.
Great. Next slide. Over to you, Jobin.
Thank you so much, Ali. Jobin Varughese, the president of the Ontario College of Family Physicians. I do receive a stipend for that position. And then also I have a role as the assistant dean of primary care education at TMU School of Medicine. Thank you.
Great. And as for myself, I do have some honoraria that I receive from different organizations, including the OCFP for this role, the OMA, Trillium Health Partners, my hospital where I work, and the Canadian Mental Health Association, PL Dufferin, where I do some educational consulting, and then have previously received honoraria on a one-time basis from the Center for Effective Practice and GSK. And I do sit on some advisory boards, including the Medical Post and the Foundation for Advancing Family Medicine as well, and the CEP. Next slide. So in terms of how to participate, just remember that all questions should be asked using the Q&A function at the bottom of the screen, and to use the thumbs up vote to the button to upvote other people's questions. Please make sure to take a look at the Q&A before you post that question, and make sure that if your question has already been asked, to just upvote that, because the most upvoted questions will be the ones that I ask. And then for the chat box, please don't put questions into there. Please use the Q&A for your questions, and use the chat box to network with one another. Next slide. As I said, this will be our order of panelists, and I will move things over to Dr. McGeer to kick things off. Next slide.
Thanks very much, Ali. Okay, so first of all, quick look at this season, and a welcome to not quite, but nearly flu-free February. Doesn't happen often, so do enjoy it while we have it. And just to note this year that you can see on the right-hand side a really short sharp flu season. So it was a little bit early, which was not unusual, but the intensity and shortness of it is quite distinctive. And it's also kind of interesting that we in Ontario had the season before anybody in the United States, which is also really distinctive and unexplained. But it's also over now. And you can see when you add up the numbers that if you compare the whole of last year's season, which was spread over a considerably longer period of time, and then add the few cases that we're going to have going forward, that this was actually in total about an average season, just came really intensely at a bad time of year at the end of December. And yes, could flu do something awful in March? Maybe, but it's really unlikely. Generally, I think we can expect that we're going to be over with flu. And finally, Danuta Skowronski's group just published their interim VE for the season. It's running around 40 or 45%. So despite the fact that it looked like it was going to be a substantial mismatch, vaccine efficacy is not terrible. Next slide. Okay, so after flu, it's RSV, right? And here you can see what's been happening to RSV in the last few years, much more stable than flu in general, but interestingly still decreasing a bit from the very first and very intense post-pandemic season. Whether that decline is we're not doing as much testing or there's some impact already of RSV vaccine effectiveness or just settling back down to usual is a little hard to tell at the moment. But we're as usual, in the middle of RSV, going to continue until sometime in March. And then finally, next slide, what's happening to COVID? So first of all, just a comparison from previous years. You see in that table at the top that the 2022-23 season, we had 32,000 hospital admissions. This year so far, a year being from September till the following August, we've had 3,100. And so there's been this steady decline. Last year, we added about 20% additional cases between February and August. So, it's still too early to know exactly what's going to happen, but you can see at least an 8-fold decline in hospital admissions and an even more dramatic decline in deaths. So on the right-hand column, you see the case fatality in hospitalized patients, which, good news here, is still declining. And so COVID is still getting better, which is really nice. But of course, the question is going to be, what's it going to do for the rest of the year? And that's next slide. Still an open question. So on the left-hand side of this, you see wastewater from Kingston, London, Peel, and Toronto, and everything looked okay except London, which has had this really sharp increase in the past couple of weeks, which has not yet been mirrored in an increase in the number of cases. You can see that cases went up in November and December, but it's really not doing a convincing thing of either cases or hospital admissions climbing at the moment. Despite that, looking at everything, Public Health Ontario is suggesting that cases are going to climb throughout February, but not at a dramatic rate. So it really is looking as if COVID, okay, it's not settling into a seasonal pattern, which is really irritating, but at least it's getting significantly better, and we're seeing far few cases and far few serious cases. So all in all, a not very exciting February and March in respiratory viral diseases, which is a very pleasant change from the last, it feels like forever, but is only 5 and a bit years. Next slide. Okay, so the other thing that set people, at least people in the media, off last week or the week before was a report from India of 2 healthcare workers with Nipah virus infection, and we're still at the stage when we hear disease that results in any change in any country, we kind of think maybe COVID is starting again. But this is Nipah virus, and it's a fairly regular occurrence. So Nipah virus is a virus that survives in bats. Bats don't get sick from it, particular group of fruit bats. And you're going to say, well, bats are corona. Are bats everything? And the answer to that is yes, okay? There are more bats in the world than all other mammals combined. And they carry a lot of viruses. And it gets transmitted, generally speaking, from the saliva of fruit bats to a whole variety of accidental mammalian hosts, pigs, cows, chickens, and humans. And within those animals, you can also get transmission from one mammal to the other, including transmission from humans to other humans. So Nipah virus is on the list of viruses that we worry about because of that possibility of human-to-human transmission, which we'll come back to in a moment. Symptoms, generally, it's a non-specific febrile illness. It causes very severe disease with encephalitis, has a case fatality rate that ranges between 50 and 70%. No vaccine for it yet, no specific treatment for it. And in the more recent cases in Bangladesh and India, there's been a respiratory component to it. By more recent, I mean the last decade, not the last year. There's more of a respiratory component, which is one of the other things that makes people a bit edgy about Nipah virus, because the disease looks a little different than it did when it was originally described 30 years ago. What's happened now, next slide, is that if you look at the inset here, up in the top corner of the border between India and Bangladesh, there were 2 cases in nurses in a particular hospital in India. Obviously, that's worried people because of the possibility that it was them caring for patients that have made them sick. They actually got sick in about the 3rd week of December, and there's been a really sizable investigation, and no source has been found. And of course, you don't know whether these nurses actually acquired it in the community, because nurses have lives too, or whether it was something that happened in the hospital. And this graph also shows you where Nipah has been identified in the last 30 years, since it was first identified in Malaysia in 1998. And the one thing that, as an epidemiologist, I want to point out, you see all the dots in Bangladesh in that inset, many more cases in Bangladesh than elsewhere. And that, of course, has got to be because Bangladesh is better at identifying it than other people, right? Viruses do not respect land borders. And so it's not that when you cross over into India, you don't see disease. It's a question of, this is really a non-specific illness, and in low-income areas of low and middle-income countries, we're probably missing a lot of disease. That's also good news, of course, because if we're missing a lot of disease, we aren't missing a lot of clusters of person-to-person transmission, because those are more obvious and worry people. So perversely, that makes us a little bit less worried about Nipah than we might be. And lastly, if you look at the next slide, Nipah is on the list of viruses that people get a little bit edgy about, okay? Got a very high case fatality rate, although that does decline with really good medical care. There's no vaccines, there's no specific treatment for it. There's some evidence of viral evolution. So you're thinking now, Nipah's an RNA virus, and people have been telling you for years that RNA viruses like coronaviruses and influenza viruses mutate really quickly, and they evolve faster and they cause problems. But Nipah's a paramyxovirus, and the other paramyxoviruses that you are familiar with, even if you don't call them that, are parainfluenza and measles and mumps, right? And measles hasn't changed in the last 100 years. So these viruses, despite being RNA viruses, are generally really stable over time. Nipah is more worrisome because there's a little bit of evidence of viral evolution and different clinical characteristics, but still, on the scale of things, not evolving quickly. People are worried because of the human-to-human transmission, and this time because these are actually the first healthcare worker infections. And I see coming up on a question about canceling travel to Calcutta in April. Absolutely not, okay? These are 2 cases a month ago in a rural area in India. No suggestion of any increased or broader risk, no reason to change travel plans. You might not want to go to Cuba because there won't be any power because of the oil embargo, but India risks are not different than usual. And there's still a lot of unknowns about Nipah virus just because it occurs in very low income areas. And so it's been hard to study. On the other hand, okay, Nipah virus has been identified since 1998. It's clearly been around a long time. Nothing has happened to it. Almost all the infections are associated with palm sap harvesting. Okay, think maple syrup. In Malaysia, you harvest sugary palm sap from the trees, and the bats like that sugary palm sap. They tend to come down and drink it overnight, and then they contaminate the palm sap that you take and concentrate and use. The viral evolution has been really limited. And it doesn't have a reproductive ratio that allows it to continue to infect patients. The infections in patients have been, generally speaking, from very close contact with people at the end of their illness when they're really severely ill and need a lot of help. And it's been from a minority of patients that this happens. So we pay epidemiologists and emerging infectious disease people to worry about Nipah. The rest of us should not be worrying about it at all. And that's me transferring over to Dan.
Great, thanks so much. So before we go to Dan, though, we'll do some question and answer just to answer some of the questions that are here. So thank you all for posting those, and feel free to continue putting more questions into the Q&A and upvoting them so I can see them. The first question I'm going to ask here is there any correlation between immunization and the decline in COVID?
Well, of course, so the decline in COVID is being driven by two things: that people getting infected and people getting vaccinated, and both of them are clearly important components to the reduction in disease. And still, we don't have data on the effectiveness of vaccine for this year for COVID yet. Still a bit early, but up to and including last year, you can still see the effect of vaccine in reducing both infections and serious infections due to COVID.
Okay. And then another question here about COVID is for London and cases of COVID, what is known about the viral type and variant?
So as you know, COVID continues to evolve. We're in, Dan, you may have to save me here. I think we're in P2s now, or maybe P3s. Okay, we went down to XFG, remember, because it was a variant, and now we're back into the rest of the alphabet. So it's continuing to evolve, but there's nothing exciting about that. Evolution's not moving faster, not causing different disease, not increasing disease in any countries around the world. So it's a little bit like watching flu evolution at the moment. Yes, it's changing, but not changing in any way that makes it different.
Thank you so much. The next thing, actually, just as a sidebar here, because you're getting a lot of messages here, and I think it's very important that we mention this today, is that Dr. McGeer received the honor of being named as a member of the Order of Canada very recently. So I just also want to personally congratulate you on behalf of our entire team as well. Very well deserved, and we're so proud of you, and so honored that you're a part of this community as well too. So thank you so much, and as you'll see in the chat, there's a ton of congratulations for you as well.
Thanks.
Of course. I'll let you just take a quick look at that, and then we'll go to the next question here. So someone asked about the Cuba comment that you made. I just answered that myself, just around that's not related to infectious disease, right? Just the political situation.
Well, not the political situation, but the fact that they're running out of oil.
Yeah.
So a lot of issues with just regular electricity and being able to cook and people being able to manage, that people are talking about starting to affect not just rural areas that have been having a problem for a while, but potentially in the next couple of months, everybody in Cuba.
Mm-hmm. Thanks for that. And then actually going back into the Caribbean, actually, there's a question here about specifically dengue cases, and are they increasing, and is there any travel advice beyond what we would typically recommend?
I don't think they've been increasing. Yes, there are more dengue cases than there have been. Yes, it is something you need to think about, but it's not on any. You've not seen warnings from people not to travel or concerns that there's a sufficient increase for anybody to alter their travel plans.
Okay, thank you. And just be careful, I guess, with mosquitoes as we always would be.
Yeah, this is an even better time than a decade ago to be really careful about protecting yourself from mosquito bites, no matter where you are in the world.
Absolutely. So another question here is, given the data that you presented, when can we expect masking in hospitals to end this season?
A really good question. I think hospitals are going to need to wait and see what happens with COVID. If COVID is increasing and we have a wave over the next 6 to 8 weeks, then we're probably talking sometime in April. If COVID just peters out over the next 2 weeks, it might be a little earlier. I think everybody in hospitals is watching because we're all keen to get masks off when we can, but faced with the fact that we may be seeing a bit of a COVID wave, it's probably not going to happen in the next 3 or 4 weeks.
Thank you so much. I'm going to also I know there were a couple questions here that were actually answered by Dan as well too, and I'll just read out a few of them just in case people can't see them because they're quite helpful. So one question that someone had was around where can we get this data that's presented on a given day, because it can be helpful for managing patients day to day. And so Dan has mentioned that the Ontario data is in the Public Health Ontario Respiratory Virus Tool, and there is a link there as well too. And if you Google that, you'll be able to find it as well. On that site, you can review testing, cases, outcomes, and projections that are provided by PHO, and those are updated weekly as well. So just as a heads up to people here.
Yeah, it's an awesome website. It takes a little bit to get used to it and to figure out where things are some of the time. But you can email them and ask if you get stuck. It's updated on Friday about lunchtime usually. But it has lots of really useful data. Really excellent resource for the province.
Perfect. Thanks so much. So we have another question here actually about the chikungunya vaccine, I guess just approved very recently, and just wondering if you could explain the decision to not give it to people over 65. Someone has a
Uh,
question about that.
no, but I bet Dan can.
Okay, we'll see. Dan, are you able to jump in on that one?
Sure. I can go quickly. So the main thing that came up in the post-marketing surveillance for this vaccine, which is again, it's used not very commonly. It's obviously not publicly funded here, but it's mostly travel related that people are getting it. Fairly recently, there were identifications both in Canada and other places for significant adverse events, including meningitis, following receipt of it. So because of that, there's been ongoing as well, but re-looking at that vaccine and whether or not it's something that should be recommended, and particularly for older adults, which is where most of the more severe APHEs were identified. They've decided to recommend against for now and put a hold on it. And I know FDA is reviewing as well in terms of potentially removing it entirely from the market. So it's very niche use right now already in terms of that vaccine, and the post-marketing surveillance identified a few serious adverse events that were of concern, which is why it's being relooked at.
Okay, thanks. And Dan, since I have you here, the next question's actually for you. So the question here is there any intel on when the provincial recommendation for the HPV-9 vaccine will be updated to align with the NACI guidance?
It's a great question, and I wish I could give an answer. It's something that's still under review, and it's a big change in program to follow all of NACI. So NACI, in addition to moving down to the one dose, also recommended expanding the program up to age 26 plus additional high risk groups. So that's a very big program change. So it's under review right now is probably all I can say.
Okay, cool. Thank you for that. This is kind of a comment and a question around, why are we sort of, I guess, having this desire to get masks off when we can in the hospitals? We don't stop hand washing just because of the season, right? And so, is there any evidence really behind dropping masking? I guess is at the crux of this question.
Yeah, so I think the answer to that is yes. Hand washing prevents all sorts of infections. Masking prevents transmission of viruses and, in a very limited way, bacteria, group A strep, okay, from being transmitted person to person. But masks also interfere with, for those of us who have hearing disabilities, masks interfere with communication. They're uncomfortable for some people, and there's just a whole lot of us that really hate masks after COVID that we'll recover from eventually. But so I think there are reasons that we want not to wear masks when we don't have to, and we don't have convincing evidence that masks prevent transmission and reduce infections out of respiratory viral seasons where we have really good evidence that they work. So masks are things you can take off during the summer, but you're absolutely right. Hand washing never stops being important in and out of the hospital.
Thank you. Thank you for that. Another question here around lots of stuff today about travel. So what about Zika virus? Do we still need to warn pregnant people about Zika virus and avoiding travel to those areas?
Again, I think Zika virus is at the stage of, particularly if you are pregnant, for all sorts of reasons, you want to be avoiding mosquito bites. Okay. And it's more important for pregnant people than it is for the rest of us, but it's important for all of us. And so I think the critical message for those of us traveling to warmer climes in the winter is about preventing mosquito bites in general.
And another kind of, I guess, nuance with this too, correct me if I'm wrong too, is that if there's a man who's trying to conceive with a partner, they also need to be careful as well, right? Because
Yep.
it can,
Mhm.
essentially live in the testes and the sperm, right?
Yep.
Yeah, so just another kind of important aspect there to also counsel the partners, not just the pregnant person as well.
Well, it's
Perfect.
too late by the time they're pregnant, okay? But
That's true. Yeah,
it's
that's true. Absolutely. All right. And then another question here is anyone working on a vaccine for Nipah?
yep, lots of people. And it's one of those things. It's figuring out how to work on it and where to get money from it, particularly now that the U.S. has bailed on funding a lot of scientific research is hard because you're not going to make money protecting palm sap farmers in Malaysia. Okay, it's just not a commercially viable operation. Because it's on the list of viruses of concern, there are indeed a lot of people working on it. Just I don't think anything close to human use yet.
Great. Thank you for that. And on the subject of vaccines as well, someone here has mentioned that at least two Ontario universities were working on a nasal spray COVID vaccine early on in the pandemic. What's happened to those? Are those ever going to come to the market?
Hard to tell. People are still working on them. Nasal spray vaccines for all sorts of things are so. Even if we don't get COVID vaccines out of that nasal spray work on those universities, that nasal spray work is still useful for a whole lot of other vaccine development. But as far as I know, um, they're still working on it. We may still end up with nasal spray vaccines. Theoretically, right? If they protect you from earlier on an infection, they may get you better, longer lasting immunity. But still, I don't think any phase 3 trials. People were close to phase 2, but
Mhm.
not licensure grade trials yet.
Okay. Thanks for that update. Another question going back to mosquitoes is in Canada, like what should we be concerned about in Canada? West Nile, anything else that we should be worried about?
Well, there's all sorts of catastrophic encephalitides. They're just really rare, right? So,
Mhm.
yes, you can get seriously ill from mosquito bites in Canada, but it's uncommon. And West Nile is probably more common than anything else, but still, it's a, you know, well, I'm not sure why you would not want to protect yourself against mosquito bites, being somebody who mosquitoes love. Okay, but it's you're much less likely to become ill from mosquito bites in Canada than in other warmer climates, but there's not nothing.
Mhm. Definitely. No, I can relate. They come after me as well too with a vengeance. So I agree. I hate getting bitten by mosquitoes. So if anything else, just to avoid that unpleasantness. And then another question here, I'll probably combine two together, is just around vaccines. So why is there yet no vaccine yet for herpes simplex is one question, and then another is asking for an update on the TB vaccine.
Yeah, so you pick, some things are just easier to make vaccines for, and we all be grateful that COVID was one of the things that's easy to make vaccines for. But think TB, herpes simplex, HIV, group A strep. There's a whole list of organisms that have been much harder to make vaccines to for a variety of reasons. And if you think about herpes simplex, for instance, you you get recurrent infections with it, right? People don't contrast it to measles. You get measles once and you can get exposed 100 times after that. You're not going to get measles again. But herpes simplex lives in not quite symbiosis, but from its point of view, symbiosis with us.
Mhm.
And so those systems where humans don't give us an example of how to build a vaccine to protect you are much harder. And TB is in that same category of people live with TB for long periods of time without being ill, right? So defining what makes you immune to it without causing any other side effects is just much harder for some things than others.
Thanks. That's very clear. That's very helpful. Thank you. And that'll bring us to the end of this part of the Q&A. But Dr. McGeer, I'd really encourage you to take a look through the chat as you will see a ton of messages congratulating you and thanking you for everything. And I would echo what people have said, which is that you always give such a amazing perspective. It's always so down to earth. It's clear, and you're able to distill really complicated information into things that we can take and use to help our patients and our communities. So again, on behalf of everyone, thank you so much, and congratulations on this very well-deserved honor. course. So next, I'm going to turn things over to Dan if he's ready to go, and we'll get the slides up as well.
Great. Thanks, Ali. Hi, everybody. And yeah, happy. I've been asking Ali and team for like 2 years now if I could come do an MSK talk and not just COVID talks all the time. And they finally let me. So I guess we'll see if I get asked for another one of these in the future based on how it goes today. But let's jump into the next slide. Hoping these are some helpful tips. I did want to say just that was funny. I asked Copilot to help me with the pictures for MSK imaging, and they gave me one of a brain imaging. So I just left it in to emphasize how we should not be relying fully on AI yet for any of these things. These are just some general principles to start with in terms of basics that I have when someone's coming in, whether they've been either like a high performance sports athlete or just someone in the community. The clinic I have is both I have a clinic at Toronto Rehab and then just like a community primary care sports clinic. So we see a whole variety of different things. In terms of acute trauma, we start with x-rays. If you think there's a fracture, dislocation, if they're not weight bearing, that's the start. We don't need to rush to CTs or MRIs for that. X-ray is an excellent tool, obviously, those pieces. If you're thinking soft tissue injury, so if someone comes in and I'm concerned for a rotator cuff tear, for example, I always start with ultrasound. Really, really good for superficial soft tissue structure, tendons and ligaments. The one thing I will say is that ultrasound, I think, as we all know, is highly technician dependent. So if you are lucky enough to be in an area where there's a little bit of variability in the ultrasound clinics, and there's one that does more MSK ultrasound, for example, try to find them because it makes a huge difference. I can't tell you guys the number of times where I've had someone referred, they might have gotten imaging from their family doctor already, and ultrasound was totally negative, and I'm like, nah, I don't buy it. And I'll send them to one of the more specialized clinics, and without a doubt, we were able to identify a difference from that initial imaging. So again, obviously, it's a little bit dependent on where you're practicing, but if you do have that luxury, it is nice to do. MRI, I do very, very rarely. And it's really if I think someone needs surgery, just as a general principle, whether that's shoulder, hip, knee, whatever it is. That's my pre-surgical imaging. That is when I'm going to MRI. And that's for a couple main things. So if someone has a significantly restricted range of motion, like a locked knee, if I'm worried they have labral tears in their shoulder or in their hip, or potentially something like that, then those are the reasons that I might be moving on to that one. If they have significantly targeted muscle weakness, again, if it's a rotator cuff tear, I'd still probably start with that ultrasound, but then moving on to the MRI in those situations. But it's really, is there something here where it's going to change my management by knowing it's a full tear that they're not able to manage? Obviously, it's most of the time you'd be able to identify a complete tear on physical exam, but depending on that person's just biomechanics, it may be a little harder. You might want to confirm, and again, getting onto surgery. And then joint instability, whether it's multidirectional instability in a shoulder, for example, if they've had recurrent dislocations, if you're worried for an ACL or PCL tear, those are, again, all the reasons that you want to move to the more advanced imaging like an MRI. So next slide, please. And I'll just run through a couple main things. So spine from, just under your skull right down to the bottom, treating it all very similar. Your thoracic spine has very little movement, so it's pretty uncommon to find significant injuries there without trauma. And we're really talking about cervical and lumbar spine. And I think we all have had it drilled into us quite a lot on how we're managing low back pain and lumbar spines and not to do MRIs. But we treat the cervical spine very, very similarly. So it's the same types of changes that we see. It's, discogenic pain that someone might be having. It's facet joint injuries that you might see, or facet arthritis. It's nerve compression in those areas. And so the fundamental principles around when I would image a spine or in a cervical spine are very, very similar to that lumbar spine. Chronic pain is extremely unlikely to give you something helpful when you're doing imaging. If someone's had low back pain for many, many years, an X-ray is probably not going to change anything. We know they're going to have some degree of arthritis in there. Have I done that X-ray just because the person really, really wanted to confirm? Of course I have. And, we all need to do our best with stewardship, but it's not the chances it's going to change management without acute change or difference in symptoms is incredibly unlikely. Our concern primarily for spine, again, outside of acute injury where there's fracture, something like that, is particularly new radicular symptoms. So whether it's cervical or lumbar radiculopathies that you're seeing, if someone's having sudden new onset, that's when we want to look a little bit more closely. And again, it could be discogenic or coming from the facet joints or other areas along the line. So you might want to try to figure out exactly where it is. Just pain by itself as a first symptom, I'm not rushing to get that more advanced imaging by any stretch. For the vast majority of people, even with just radicular pain, that's still manageable with conservative management in terms of, physiotherapy, your core stability exercises, those sorts of pieces. If they're having advancing symptoms, particularly, you may be losing deep tendon reflexes, you may be getting some targeted weakness. If it's radicular, if it's cervical, then you might be seeing maybe changes in some of their grip, for example. If it's lumbar, they might be dragging their foot, whatever it is. But if they're seeing that targeted weakness, that's when we're getting more concerned for sure and going to either more advanced imaging, or one that is very, very helpful would be things like nerve conduction studies and electromyography. So I'll do those ones if someone, again, if has new targeted neurological radicular symptoms like that weakness, for example. I want to get a sense of that nerve health and how urgently are we moving to something like surgery. And the EMG is a really, really good way to do that. The other thing is it may be sometimes a little bit questionable exactly where the compression is on those radicular roots. With lumbar spine less often, but for cervical, it certainly could be from the spine, but it might be a little bit lower down. Maybe it's more brachial plexus. And you might want to be trying to localize it better. And again, the nerve conduction study and EMG are really helpful for that. So next slide, please. So rotator cuff, again, imaging, I'm not doing any imaging for just standard rotator cuff pain, impingement signs, anything like that. If there's concern for an actual tear of the rotator cuff, like we're having targeted weakness in a particular muscle group, that's when I start with the ultrasound. In an individual over 65, MRI is probably not going to be of value. For everybody over 65, we're going to see degenerative changes in that rotator cuff, including degenerative tearing, and it's unlikely in most cases to be useful for a surgical intervention later on. Again, this is obviously dependent on your patient. They're wonderfully healthy 65-year-olds with sudden acute injury that we're still going to do it, and there's differences. But if we're talking about chronic pain and just kind of chronic degeneration, that MRI is not likely to be of value. The times that we're going to MRI, in particular MR arthrogram, is if we're concerned for joint issues like labral tears. So if someone has labral signs on examination, so like O'Brien's test, if they have instability on apprehension relocation, for example, if you're concerned that there's damage to the labrum, the MR arthrogram is still the gold standard. We can get decent labral imaging from the 3 Tesla radiology MRI machines. Those aren't necessarily available quite everywhere yet. With the 1.5 Tesla ones, it's not great if there's no contrast from the arthrogram in getting a really good picture of the labrum. So they'll often say, suspect labral tear here, etc., confirm with MR arthrogram. But if you really want to rule out a labral tear, if you have concerns and think there's a surgical labral tear, that MR arthrogram is the one to be looking for. So next slide, please. Elbow, I could probably count on one hand the number of times I've actually done imaging for an elbow. It's incredibly uncommon. Yes, if someone has potentially severe arthritis and limitation range of motion, you want to identify that. It's not nearly as common in the elbow as other joints. For any sort of chronic pain or even acute pain without mechanical symptoms like locking or limitation, it's unlikely to be of value. The most common thing we see in elbow, of course, is epicondylar injuries like tennis or golf elbow. There's no reason to be doing ultrasound for those. We don't really see any benefit in the imaging. We still just manage with the conservative exercise that we start with. Again, that X-ray is really for if you think there's bony problem that we're looking for, fracture, dislocation, significant arthritis, that might be something surgical. Similarly, if there's ulnar nerve damage that you think might be there, if they're having ulnar neuropathic symptoms, again, a lot of that is identifiable on clinical exam. An ultrasound can help if you think there's ulnar nerve impingement going through the canal, which is something that might be warranted depending on their symptoms. And again, if it's significant ulnar nerve symptoms, but you're saying, well, is it more ulnar? Maybe there's some carpal tunnel component. That's when that nerve conduction study and EMG can be really helpful again. Next slide, please. Hip is very similar to shoulder if we're talking about what we're doing for imaging for many cases. So probably the number one reason I do x-rays for the hip in my practice at least is looking for femoral acetabular impingement. So that is when you see those bony changes where you're either getting increased overgrowth basically of the cup for your hip, or you're seeing loss of some of that rounding of the femoral head. There's specific imaging we're doing for that, a done view and frog leg, which identify it. This is what we see really commonly, like particularly in hockey goalies, but lots of younger athletes if you're seeing restriction in their hip range of motion. And it is a risk for labral tears in the future. So if someone does have significant FAI, that is also probably potentially a surgical intervention depending on the level of activity and what they're doing going forward. But starting with that X-ray, and the X-ray is the perfect for it. If you think, again, we've already progressed to something like labral injury, then that MR arthrogram, again, is the gold standard and the best way to identify exactly that labral tear. Lateral hip pain, so, classic bursitis sort of pictures or greater trochanteric pain. Again, extremely rarely that I would ever do imaging. At most, start with an ultrasound if you're concerned there might be an actual tear of some of the tendons attaching to that greater trochanter, but it's really, really uncommon. The only other time would be if someone has like lateral hip snapping that we have concern is not going away, like painful lateral hip snapping, for example, and we're trying to better characterize exactly what that is. Those, again, may potentially be surgical if it's gone on for a while and failed conservative management. Next slide, please. Okay, so knees. The number one thing I can say is that I get an awful lot of referrals for knee arthritis where someone comes with knee x-rays that were not done standing. So if you are going to be doing x-rays for evaluating knee arthritis, standing x-rays, not supine x-rays. We need to see weight bearing on that joint to be able to characterize arthritis properly. The other thing is I see a lot of knee ultrasound referrals that come in. There's very, very few reasons to do an ultrasound of the knee. So if we're trying to get into the knee joint itself, obviously the ultrasound doesn't give us a good picture of that meniscus. Maybe if you're lucky, you get the very outside of the meniscus. And that potentially is a value, but very, very rarely are you going to see something in terms of ultrasound for the meniscus that wasn't easily identifiable on physical exam. If there's been a clear MCL, LCL tear, that might be a reason to an ultrasound to just confirm if you're questioning that it's there for sure. It's usually, again, pretty obvious on physical exam if there's a full tear of the MCL or LCL, but that's about it for ultrasound. Most of the time when I get in terms of referrals is someone had a knee ultrasound, they have a fusion, they have a Baker cyst. Should we do anything about it? Probably not in any of those cases. The X-ray is the gold standard. If someone has arthritis on their knee X-ray, then MRI, that knee is not likely to be of value. X-ray is excellent in terms of knee imaging. We would move to MRI if, again, we think there's one of those surgical indications like a significant meniscal tear, significant one, particularly with mechanical symptoms like locking, like giving way or buckling, an ACL or PCL rupture, for example. Those are ones. Or if you're having really persistent pain with a negative X-ray to start, those would be the indications to move to MRI for the knee. Next slide, please. And ankle. So this is a tough one because ankle and foot we look at together, and feet are very complicated. There's lots of little tiny bones in there. There's lots of small ligaments that can be injured. So it is something that we look at pretty clearly. If there's any concern about weight bearing in the joint, then yes, we would start with an X-ray. We want to be sure there's any small fractures from someone who's had an ankle sprain. Potentially, if they're not weight bearing, we want to be on the lookout for things like high ankle sprain, and if you start to see some of that widening. But really, an ankle X-ray is not done commonly, and for a kind of a run-of-the-mill inversion ankle sprain, I almost never do imaging at all. Most of the time, if someone has that standard little ankle sprain, we're not going to see anything significant injury. Yes, they'll get the ultrasound. Yes, it'll confirm an anterior talofibular ligament tear. We already knew that was there because they had an ankle sprain, and that's the mechanism. That's what happens. So it's unlikely to be of value in just a classic normal ankle sprain. The other thing I get a lot of referrals as people get a lot of X-rays with heel spurs. Heel spurs are pretty rarely the cause of someone's symptoms. They're usually a symptom. So if you have chronic plantar fasciopathy, for example, for years, that's pulling on that bone, you're going to get bony buildup. You're going to start with calcific tendinopathy, and then as you're going to get that bone continue to build to a heel spur. It's rare that the heel spur is large enough itself to be causing the symptoms. Again, it's mostly a symptom of what's been going on a long time. So don't specifically order X-rays to look for those heel spurs. If someone has chronic plantar fascia type pain, manage that chronic plantar fascia as you normally, and that heel spur is probably going to be secondary to what's been going on. I think that's basically it. I wanted to do just like a quick run through. These are some really helpful references all the time they use. The Canadian Association of Rheologists one is great. ACR has like a wonderful tool to run through by acute, chronic, new symptoms. Lots of really, really good resources out there if you have questions about what's the best and most appropriate imaging for something that's coming in. So hopefully I'm okay on time there, Ali.
Yeah, that was perfect. Thank you so much. So I'm going to pull up the Q&A because we do have quite a few questions here. So I got first a very practical question. So how do you talk patients out of lumbar MRIs, which I'm sure you've dealt with, where patients really have a strong idea. I saw it on TikTok, or my friend had an MRI, my neighbor had an MRI, I need an MRI. How do you talk them out of it?
Yeah, it's a great. I still at every clinic I have a patient where that's the case, like literally everyone. So, it's a few things. So number one is if you've done your good physical exam for someone, you already know exactly what is wrong in that back, right? If they're having clear flexion provoked pain, you know that there's a disc. If they're having clear extension provoked pain, you know it's facet joint. And I think that being able to explain to them the mechanics of the low back that we know you almost everyone gets degenerative changes at some point. These are two types of things we see very clearly on exam. I know what the problem is right now, and that MRI is not going to be changing any sort of management of it. That's really what I go through with patients. And then I go over the indications for MRI with them. Are you getting new radicular symptoms that we're concerned about? Is it severe pain that you're, suddenly having that we think might be surgical? And especially once you bring up surgery, and people rarely want surgery in my practice at least. They don't want to have to go there. So I say if we're doing MRI, it's because we think we're having surgery on that back, and I don't think that's the case. And I would say the vast majority of the time, it does take the time to counsel them on that and do the explanation, but most of the time people are very comfortable with that.
Great, thanks for that. And then do you have a go-to resource for exercises when you're recommending people to self-manage, especially if they can't access physiotherapy?
For low back, absolutely. So the rapid access clinics have a wonderful website with like they have videos on it now in terms of patient exercises start. They have excellent handouts based on the type of pain, whether you're extension provoked, flexion provoked, whether you have constant leg pain, intermittent leg pain. It's all there in terms of patient handouts. So that's the number one that I use for low back pain. And it's pretty easy to get into it. And Jobin just put in the chat, which is excellent.
Amazing.
But it's great tools, videos, etc. And then if you think they need a little bit more beyond that, you can always refer them to the rapid access clinics for that initial assessment. Or, sometimes it's just kind of one, and this is what I try to emphasize, one physiotherapy session for someone to show the exercises and how you can do it based on what they're doing. It's not something you need to be, repetitively for.
Mhm. Yeah, and I will say from my own experience as someone who had a bad back injury that, it really emphasized to me the importance of doing those exercises. And certainly it can be helpful to be taught them, but you have to essentially just make it like a practice, like just every single day doing them. And I found that's what made me get so much better. So it really speaks to the importance, like from my own lived experience, that
Yeah,
you absolutely need to do those exercises and no one can do them for you. You have to do them yourself. So I really try and emphasize that with my own patients.
exactly. The homework what matters and planks all day.
Yes, exactly. Yep. All right. Another question here on the topic of physios. Is there OHIP or free or low cost physiotherapy for younger adults without private insurance?
Really, really good question. So if someone is on Ontario disability, then yes, they can still qualify for the OHIP covered clinics. Otherwise, unfortunately, you're a little bit limited. So most of the universities do have, student clinics that you can go to that are lower cost for physiotherapy, chiropractic, that sort of thing. That's usually good. And if they're hopefully still under their parents' insurance, they can get things. But it is I mean, this is something that I talk a lot. This is a huge gap in our system in Ontario. The inability to access like rehab services and preventive physiotherapy and other services like that for chronic MSK issues is a real limitation, and it is a difficulty that we struggle with. So, try to find, there is the few things under a hope that you can get if people have ODB, for example, student clinics. There are some clinics that will work with, if there's partial insurance, that sort of thing, but it is a really difficult thing to do.
Yeah, definitely. Yeah, it's a major gap in our system. Sometimes too, family health teams might have physiotherapists as part of their team. It's
Yep.
rare, but I know that some do. Like mine, for example, we do have a physiotherapist there that will see patients in that category of not covered by OHIP, but younger adult sort of situation there. So sometimes there can be resources in your community, so it's definitely good to ask around. Okay, I see another question here around sciatica. So I still hear the term sciatica being used by physicians to refer to any pain radiating down the leg. Is sciatica only constant leg dominant pain from radiculopathy? What anatomically is the cause of leg pain that is not constant if it is not nerve compression?
Yeah, great question. So sciatica, is kind of a bucket term for any of these ridiculous and like radicular pain that people are having. So it's if we're talking about management, in particular surgical management, it's a little bit less helpful to say sciatica. We want to localize this. Is this an L4 radiculopathy? Is it L5? Is it like what exactly are we seeing here in terms of radicular symptoms? So that's really what we're trying to do. So I don't diagnose sciatica. I diagnose radiculopathies. And I localize them based on the presentation of findings. So if you're having that clear right down the back, all the way to the back part of your leg, we have a clear S1. You're going to localize again if there's, any myotomal interactions with that as well. But that's the key thing. Sciatica is again just that bucket term we're using for any of these. Some people use it for like just buttock pain, even not even clear radicular symptoms. Just on that note, like buttock is not necessarily and usually not radicular. This is just part of your low back if you're getting high buttock pain, for example. So I wouldn't be jumping in and saying that, yes, you have clear sciatica and radicular pain if you have buttock pain. It's if we're going all the way down the leg, particularly lower than the knee, but you might have just anterior thigh pain depending on exactly what level of your lumbar nerve roots is being affected. Hopefully that answers that.
Yeah, definitely. No, that was very helpful. Thank you for that. So another question here is around, unfortunately, I find often when a patient has not improved with physio and a referral to an orthopedic surgeon is required, for example, for Depadrol, if I haven't ordered an MRI, they won't accept the referral without it. Any suggestion on how to manage this?
Yes, so that is absolutely the case. So if you're referring to orthopedic surgery, they are often going to require imaging. They are surgeons. They base this on imaging. One thing I can suggest is if they think that they haven't responded to conservative management and you want to send them for injection, something else, and you again are in an area that happens to have them, you can always send to a primary care sports medicine physician. They are not going to require imaging before seeing that patient. And so that might be a good first step that you can use. Um, if you're referring to orthopedic surgery, they're often going to need at least an X-ray before going to see them. And that's just the case in terms of system because they're so overloaded with patients. They need that as part of their triage protocols. So again, I think the best recommendation is see if you can find a non-surgical clinic to send to, like a pain clinic, for example, primary care sports medicine that won't need that imaging in advance and can do some of those next steps in terms of injections or other measures before needing to get to the surgical consult.
Yeah, and I was gonna say too, like I found in my experience as well that oftentimes if the sports medicine physician feels that they need to see an orthopedic surgeon too, they can often, expedite that process too as well. So it can be very helpful to get the sports medicine input as well and see if they actually truly even need surgery.
Exactly.
Yeah, awesome. Okay, so then the next question here is I don't think family physicians can order MRAs. It has to be an orthopedic surgeon. So I would say that really just depends on where you work. Like I know where I work, for example, I can order them, but I think it just depends on where you work.
Yeah, I'm probably speaking from a little bit of privilege that like I'm practicing in the GTA. I have no problem ordering MRA, but depending where you are, if you're more rural, they may not even have MRA available, right? So that again, this is where it's some of the discrepancies that we have in inequities within the system, depending on where you're practicing. That's still the gold standard for that labral tear. Could you start with an MRI on a 1.5 Tesla machine? Sure, you could, but it's going to be difficult to characterize. And probably if you do that and then get them to orthopedics is going to then get them to that more advanced imaging.
Mhm. Thanks. Another question here is, what's your take on piriformis syndrome?
It's a great one. So this is one that certainly like physiotherapy, chiropractic really like to call that a lot, someone having piriformis syndrome. A true piriformis syndrome, like solely piriformis, ongoing inflammation in that area is pretty uncommon. Like I've certainly seen it. I think it gets overcalled quite a bit. And it's usually just one component of like a broader picture that we're seeing in terms of piriformis, glute, etc., both weakness and like mechanical disadvantage with moving. So, is it helpful to still work on piriformis along with your glutes when you're doing that rehab? Absolutely, to that strengthening. Is it going to feel better if someone's sticking fingers in there and doing some manual release? For sure it is. Is it likely to be that someone has sole targeted just piriformis injury that requires like a steroid injection into their piriformis? It's pretty uncommon. It's mostly ends up being part of a broader picture.
Mhm. Okay, thanks. That's helpful to kind of contextualize that a little bit more. All right, another question here, this is more of a system question, is why do X-ray places not do standing X-rays for knees as a baseline?
It's a really good question. And if the indication that you've put on your requisition is arthritis or in some way, they absolutely should be doing a standing. You can't properly evaluate arthritis with a supine X-ray. So as to why that isn't the standard, I wish I could say. So if it's not looking for arthritis, sure, it might be fine. If we're looking for fracture, dislocation, something like that, then a supine is totally reasonable to do. Um, but I think, making your indications very, very clear and just ensuring that you write standing on it is the safest way at this point in time. Again, we're getting into some system problems here for multiple things now, Ali, and I don't think that I can solve them on this call.
Fair enough. Now, I guess another question actually on the subject of imaging is that like sometimes I've seen where like they want multiple views, like they want the skyline views as well too, and those is that like a typical standard practice that we should be doing all the time is like ordering the four views, or what would you
Yeah,
recommend?
that's the gold standard. Probably something I should have put in here, but yeah, that would be gold standard for evaluation of arthritis in someone's knee because we want to see all three compartments of the knee, the medial, the lateral, and the patellofemoral. And that's the best way to really characterize what we have for somebody. And so you need all of those views to get the best possible characterization. So again, if you're going to be working them up for knee arthritis and getting that X-ray, get all the appropriate views.
Yeah, it saves you some time later, right? And I have found in my experience that like if I write four views, then they do it.
Yeah.
But you have to write it actually in the indication for them to do all of those views.
Yeah. If you don't write it, they're going to do an AP lateral, and that's it.
Yeah, exactly. Yeah, exactly. Okay. All right. And then another question here is there's quite a few questions here, Dan, which I might just get you to maybe answer like just by typing because it's very specific. Like people are asking for recommendations you might have for referrals and things like that, but specifically in downtown Toronto.
Oh, sure.
Just because I know we have an audience that's around Ontario as well too, maybe I'll move over to a different
We can
question, but
follow up at a
just
later time on that, and I
yeah,
think
absolutely.
yeah.
Perfect. Okay. So the next question here is, are the Ottawa knee and ankle rules still the best practice?
Yeah, absolutely. I mean, I didn't put them in here because I think we're drilled into all of us, but that's the standard that I would use for whether X-ray for is warranted at that time. So absolutely keep using them.
Okay. Another question here around rotator cuff tears and surgical repair. What is the evidence around timing of surgery? And when is it, if ever, considered too late to do it? And then a follow-up question to that is also, what is the evidence for preference to do repair for those under the age of 65?
Yeah, so I'll start with the second one. So it's really because again, it's very individual dependent in terms like we use 65 as a cutoff because that's our general older adult cutoff and where we obviously see more degenerative changes. The issue is someone is over 65, they likely have poor quality tissue. Like to put it bluntly. So if you're trying to do surgery on them, it's already going to be somewhat atrophied, it's going to be thin, it's going to be really difficult to do, it's going to be more prone to tears. And they're not likely to get as much benefit from reattachment. The other thing is people over 65, it's usually not acute tearing. If it's chronic, it's been many, many years, then you're not going to see the recovery in the same way. And they've probably already mitigated a lot around their activity and movement so that, if the goal is, what's the goal of surgery? Is it to give them more function? We probably won't see that for someone in that age range, right? Again, individually dependent. There are wonderfully healthy 65-year-olds that I would absolutely, 75, 80-year-olds that absolutely would still do surgery on. The first part in terms of timelines, realistically, if we're talking about an acute tear, then the sooner the better. The issue is if we wait, we start to see retraction of that tendon and it gets to be a much more difficult surgery. You get scarring that then has to be released as well. And so it's really hard. So if you think someone has had an acute injury and they have a complete tear of a rotator cuff muscle, that's, again, like I said, get the ultrasound really quickly, but you might even want to get the MRI in the books if you're that confident. Once you have the ultrasound showing it, you can send that referral and say MRI pending. Usually that works quite well if we're talking about getting to see surgery. And then they'll get them in as quick as possible. particularly for younger people where it's directly affecting their function. We want to do this really fast because the outcomes are better. If you identify it later, if it's been, months, it's still can help, right? We're still going to get through it. It's just a more difficult surgery and more difficult in terms of the rehab. The other piece that I can't emphasize enough for anything surgical is prehab is so important. So yes, you can't get that one specific tear, but you can do everything else in the rotator cuff around it, and that will make the rehab and the recovery so much better.
Great. Thanks so much for that. All right, another question here. This is actually going with your public health hat. So, someone's asking if we need the red top viral swabs frequently to test for HSV. We have always obtained them from public health, but have not found another source to get them. And I think I saw a mention in the chat earlier about not being able to order some of these tests anymore from the public health lab. So, just wondering if you could comment on that a bit because it's come up a couple times.
Yeah, honestly, I'd have to double check on like specific tubes and vials for everything. That one, I don't keep quite up to date, and I know that Public Health Ontario just sent out information about not providing stuff anymore in terms of some of the test kits. I would strongly recommend everybody follow up with Public Health Ontario and email them and call them to see what they can do.
Okay. One last thing here is I just
Allison
wanted
jumped
to.
in case she wants to add on that.
Oh, sure. Yeah. Sorry about
Well,
that.
so I do think ordering red cups in general, there was a shortage of them because of the really intense flu season. So a piece of the problem with people ordering things in the last few weeks may have been just that we ran out of them in a variety of places in Ontario, but they'll be back.
Thank you. Thanks
Thanks,
for that.
Allison.
All right. I do have one quick announcement we wanted to do before we move on, but I might ask you one more question, Dan, which is actually
Sure.
about thoracic outlet syndrome, because I feel like that's one that we don't often think about, but it has come up, I remember once in my practice. And just curious if you could give us a sort of what we should think about with that one in particular, because it's less common, but something that's important.
Yeah, so there's different types of thoracic outlet syndrome you can get, right? There's neurogenic or vascular. A classic true thoracic outlet is someone who has like an extra cervical rib that's causing compression, but there are other ways to get some compression thoracic outlet. There are some very specific tests that we would do to identify whether it's neurogenic versus vascular in terms of, Addison's test, you have arm raising, you're following along with if you're seeing a loss of their circulation with it. But it is something that it's not super common. It's something that I see. Um, that's a great indication for an X-ray to start to see if there's a cervical rib or something that might be causing it. But again, we do see muscular types of thoracic outlet or like broad picture of similar looking appearance in terms of the nerve symptoms, where it might be due to, compression anywhere along the chain, that can happen. So like, yeah, it's worth looking for. Probably we need to come back to give a more in-depth on thoracic outlet, but I have seen it's pretty uncommon to have a true cervical rib thoracic outlet. Like I think I've seen maybe 2 or 3 in my career, which is, I was just looking at the day, it's getting to be long now.
Awesome. And then just to, help answer the one question about referrals, just one thing that's being highlighted in the chat here that I'll flag for people is the rapid access clinics that exist. So they can be accessed through a centralized referral process, which is really nice. And I believe most communities do have them in terms of an access to a rapid access clinic for low back pain. And so these clinics are free for the patient. They're province-wide. They give you quicker access as well, too, because they do have inroads with spine surgeons. They have inroads with diagnostic imaging typically as well, too. So if imaging is indicated, they'll expedite it for you as well. And they also will get an exercise program. They'll get follow-ups typically as well, too, with that program for a time-limited period. And it's all OHIP covered as well. So I've had great experiences with that, too, in my own practice. And it seems like others have said the same.
It's a fantastic program. I've been referring since they were the Isaac clinics and just
Yeah.
whatever it used to be called. But yeah, go through the process. You got to register as a provider with them. They'll give you some like basic training on identifying low back symptoms, but it's really wonderful.
Amazing. Okay. We gone a little over time with my questions, so we're gonna go to the next piece just to make sure that we get through some of our other content here. So next slide, please. And if we can pull up the slides again too. And I'd like to also welcome Dr. Tara Kiran, Vice Chair for Quality and Innovation from the DFCM, who's here for an announcement. If we could go to that one first, and then we'll come back to the OCFP. So if we can just move a little bit down the slide deck for a second. Thank you.
Hi, everyone. It's so great to virtually see you and be part of this community. I just wanted to give people a quick update about things that that'll be going on behind the scenes. As you know, we have a wonderful team that prepares these sessions and works hard to make them really relevant for you. Dr. Eleanor College, for the last 2 and a bit years, has been our CPD program director at the Department of Family Medicine at U of T. And unfortunately, she is stepping down. She's decided for various reasons to do so. But we're super fortunate that she loves the COP so much that she's going to stay on as a co-moderator here at the COP and continue to be on the planning committee. So just a huge shout out and thank you to Dr. Eleanor College because she's actually been the chair of our planning committee for the COP and really helped to transition it to something sustainable in I always hesitate to say post-COVID-ish, or at least post-COVID emergency world. So, with Eleanor stepping down, we're really excited to welcome a new team member, Dr. Stephanie Zhao, who I'm sure you'll be meeting soon. I'm not sure if she's on the call. I don't think so, but is she there?
Yeah, she is.
Anyway, she is. Okay, so I'll let Stephanie wave. So Stephanie is a family doctor that practices in the North York area, who also does addictions medicine at Sunnybrook Hospital. And she brings a wealth of experience in CPD, including lots of financial savviness to our department, but also, has actually been chairing the Practicing Well community of practice. So she's going to be taking on the program director role for continuing professional development in our department, and she'll be on the planning committee, but not moderating here at this COP, but continuing with the Practicing Well. So excited that Ali's going to take on the role of chair for the COP, and we continue to really want to get your feedback and recommendations for how we can continue to keep this forum relevant and useful to you. So thank you, Ali, for taking on that new leadership role. And I also wanted to give a shout out to Dr. Harry O'Halloran, who's been on the planning committee now for quite a while. It's been wonderful to have his perspectives. And in particular, I think, sometimes we can be a bit GTA centric. So we really want to hear from you guys outside the GTA to ensure that we are really providing perspective that's relevant to all of Ontario. And with that in mind, I think we would really love to recruit some new members to our planning committee and get your feedback. So as always, we have evaluations at the end. You can give your feedback around what topics you want. But Ali, I think there's also a slide just to recruit some new members. But I'll turn it over to you to do that. So thanks to everyone. And of course, thanks to Dan and Allison, two stalwart presenters who've been here since 2020.
Thank you so much, and thank you for joining for that announcement, Tara. I really appreciate it. So we can actually go back in the slide deck. We'll go back to the OCFP updates, and I'll turn things over to Jobin for that one.
Yeah, thanks. And thank you, Tara, for that. Just a couple of quick points on ways that we've been busy at work trying to improve primary care for family physicians. Currently, there's a pre-budget submission that we've put through. We've spoken, one of our colleagues, Dr. Jocelyn Charles, spoke to the committee in Toronto, and we presented to a couple others across the province. As we go to the next slide, this has been something that we've been doing a fair bit, but as has been mentioned here, the changing the way we work community practice is one of many community practices that we have with the DFCM. And so the Health Equity Community Practice for Family Physicians has their next session on February 19th. Practical Strategies for Supporting Patients on OW, Ontario Works and Ontario Disability Support Program. So I do ask that you consider getting that. Next slide. Practicing Well also has sessions as well. And so just to point out that there's a couple of sessions coming up, February 25th, March 25th, and don't forget about our Peer Connect mentorship. This is also a really important place where you can have the ability to have peer learners and be a mentor as well. Next slide. Another big thing that we're doing are these small group learning sessions. So we're trying, if we go back one slide, we're trying to ensure that we can have more of our sessions done over time. And so this is another way that we're connecting with you. So feel free to use these. We do have a registration deadline of March 9th, so please consider applying for that. All these slide decks will be available for you afterwards. Next slide. And also, there is a workshop for children's mental health and the foundations of children's mental health. We've been hearing from people that they've noticed an increase in the types of complexities that they're seeing within this. So we wanted to have more professional development in this field. And so this is a brand new 3 credit per hour virtual workshop that you can consider doing. And you'll see here on the slides the different areas that are part of the learning objectives. Next slide. And then, as was already discussed, we are absolutely looking to expand our Change the Way We Work planning committee. And we are really looking to see if we can get outside the GTA, similar to what Tara just said. So if you are interested, all the slides will be provided to you afterwards. Angeline has put in the chat the link. Please consider applying. We'd love to hear from you. Thank you. And I think with that, I hand back to Ali. Let's just see the next slide.
Perfect. Thanks. So just as a reminder for everyone, you can watch previous sessions and you can obtain credits for those sessions as well too. So here are a few of the more recent ones that we've had. And as you can see, a variety of different topics were discussed as well. So please do check those out at the link that's there. And this particular session will also be sent to you via email, so you can access it if you'd like to watch it again. Next slide. Please save the dates for our upcoming sessions. Our next one is going to be on February 20th, so just in a couple of weeks. And then we have a couple sessions planned for you in March. Registration links will be emailed to you closer to the date, and please do fill those out and send us your questions so we can plan you a great session. And with that, I'll close things off. Thank you all so much for attending today. Your session slides will be available later, and we will see you on the 20th. Take care and have a nice weekend.